Uh, I'm Nasrat Rasa. I just explained that I was trained as a medical doctor initially, but I never practiced in the health setting. So I then moved to public health and later on to WASH. So WASH is also a determinant of health. So I don't consider it very separate from public health. So I did my master in public health in the US, in St. Louis University. And then most of the time I worked in Afghanistan with various international organizations. My last job was with UNICEF, where I was leading the sanitation and hygiene team. And what I'm presenting is mainly what we've been doing there in Afghanistan. I also worked in New York for a short time with the WASH team. And I also traveled to other countries in South Asia and visited programs there. So what I'm going to present now is slightly different from what it is in the title of the presentation. The title of presentation says Hygiene for Health and Dignity. To be honest, I was trying to combine my work with health center and also the menstrual hygiene, but then I couldn't find enough material here on my MHM work. So therefore, I will be focusing on my work with health centers, the health center hygiene program. So, and I apologize for any inconveniences. So I'll briefly talk about the country and the context, and then later come to the program itself, and then what the problem there was and what our proposed solution was and how the approach that we chose was. And I will also talk a little bit about the process and some of the results that we achieved, and then the challenges we face. And finally, I will end the presentation with some of the lessons that we learned. So, Afghanistan, it's a mountainous country, very water stress, especially in the recent years. It was affected by drought, many of the places in Afghanistan. And yeah, everybody knows it is a conflict-affected countries. So it's the population is 42 million, and it's a very young population. Almost 47% or half of the population is under 15 years of age. When it comes to access to WASH services, the access to basic WASH water is not so bad. It's 75%, but still 25% of people don't have access to water. And as I mentioned, it's a water stressed countries, and those 25% people live in areas where water is very scarce. Basic sanitation is 50%, and basic hygiene is 38%. 1/3 of health centers don't have safe drinking water and sanitation facilities, which meet the definition of the basic. It doesn't mean that they don't have anything. So, what I'm going to talk about is not a very typical WASH project, because normally WASH projects are water or sanitation in the rural or urban communities. But recently we know that health centers and other institutions, including school, they are also places where we have to make sure that people have access to WASH services. And historically, we know that hygiene was an important element of the public health services and also the healthcare. Probably you all heard about the story of Agnes Semmelweis, who discovered in 1847 that hand washing was important for the prevention of diseases. Even at that time, people didn't know the germ theory. And the recent data shows that people visiting health centers are prone to getting infection. 1 in 10 patients get an infection while receiving care. 10% itself a lot. And when it comes to those infections, most of them are antibiotic resistant. So in one study, they found out that 50% of the surgical site infections were antibiotic resistant. And then we also know that IPC and hygiene, that's the solution. So if we have effective IPC, we can reduce at least 30% of those healthcare associated infections. So therefore, that's like the global problem. How the idea came to mind in Afghanistan and in our context. Afghanistan is one of the countries where the neonatal death is very high. So we were reviewing some of the studies there. In 2017, UNICEF supported the Ministry of Health to conduct the maternal and newborn quality of care assessment. And we were reviewing that assessment, and we found out that some of the indicators related to hygiene are very poor. Despite, 81% of the health centers have access to hand washing facilities, water and soap. The practice in itself was very low, it was like as low as 24% by midwives who are providing life-saving services to mothers and children. So then we did a little bit of analysis in the Health Management Information System, HMIs, and we found out that many health centers don't have safe drinking water. Some of them have drinking water from other sources. They bring it from a distance, but it doesn't meet the definition of the basic drinking water. And when it comes to latrine, almost 23% of them didn't have latrine at all, and then 37% didn't have access to improved sanitation. So, and then we also observed that hand washing practice was not very good. So in addition to what we found in the study, we also visited some health centers. Some of them were missing, soap. Some of them were missing hand washing station water, and then we also found out that practice was not very good. So therefore, what we did, we thought about a concept which were focused more on prevention of the risk to the newborns. So we were thinking since this newborn mortality is very high in Afghanistan, if we do something and improve the hygiene practice, then we were hoping that newborn mortality will reduce. And then we were thinking since this is a behavioral issue, so it's more of practice issue, therefore it's good to focus on behavior rather than facility. But of course we have to have an integrated approach. And then we thought hand washing would be a good entry point for us to enter the health centers and talk to healthcare providers. And then we also know that when we build local leadership capacity, then the behavior is sustained. And later on, we also added a social recognition and modeling into the program. I'll talk about it later on. And continuous internal oversight and supervision by the health facility staff itself, not from outside. And then we were also thinking of using some triggers for behavior change. And we came across some of innovative nudges and reminders, and then some posters and brochures and messages. And then we tried to create an internal follow-up within the health centers, not from outside. And also we added facility improvement. So the first thing we did was, to get buy-in from the relevant partners and stakeholders. Since this model is inspired by the WHO multimodal method, WashFit, which is a very known package, and community-led total sanitation. Because in these models, especially in the community-led total sanitation, it's huge on collective behavior change rather than introducing so many facilities. Then what we did an internal consultation with our health program inside the office, and they also agreed that this is a challenge that or an issue that we have to address, and they would support us. So then we did the first draft of the concept. We finalized it internally. Then we tried to do it through the Ministry of Public Health, because Ministry of Health is like the main steward of the health services. And we went there and we tried to find a champion there. And luckily, the health promotion department, they were very supportive of the idea. So we engaged them from the beginning. And then we organized consultative workshops where Ministry of Public Health and NGO people were invited, and then we refined the concept, and then we finalized it. We started implementation of the program. This is the theory of change for the program. It's very condensed, so that therefore I just develop another one, which is a very summarized version of it. So the main idea of this program is that, there is a set of intervention, joint assessment of the health facility in terms of hygiene and sanitation, then doing triggering with the staff, and then follow-up visits, and then turning health facility into hygiene models. So these are like the main intervention package. And then it would lead to a set of outputs. Outputs would include health center personnel practice hand washing with soap through collective decisions. Health center adopt improve hygiene and sanitation practices, and health center staff would carry out regular sanitary inspections of their health center. And then the environment of health center is clean, and finally the health associated infections would reduce, and as an outcome, and the impact would be reduce newborn deaths, and it would also reduce maternal deaths. So this is the main theory of change, how we envisage this program to work. And this is how we would, this is what we would use with healthcare providers, because normal healthcare providers, they have a lot of knowledge about diseases and how they are spread, and so this is adapted from the WASH Fit and WHO material, so that they know how water sanitation facility improvement can stop spread of infection, and then in the long term improve health for women and newborn children. So the process of this program, how it worked, this program had a couple of stages. The first stage was like in CLTS, we call it pre-triggering. So we had the same. We would just get appointment from a health center, and we ask them that in that specific day, everybody is present, including, healthcare providers and non-healthcare providers, like even the admin staff and the cleaners, everyone. So on the day of the intervention, we would go and we would have a transact walk of a health center with everyone, just to see, how the health center looks like, how the water facilities, sanitation facilities, hand washing facilities, and overall cleanliness is. And then we would just take notes. And then we would have a meeting with everyone, the triggering session. So in that triggering session, then the main messages would be like delivered to them. Some of the findings would be shared with them, and how those findings are linked to improving hygiene, and how the healthcare providers should decide on how to improve their situation in the health center. And then jointly with them, we would develop an improvement plan. So in that improvement plan, they would also include both behavior change elements and also the facility improvement, and they would identify some of the gaps and then also suggest solution. And then later on, our staff would then make follow-up visits to see how the plan is being implemented. And then later on in the program, we also added another element, which was certification. It was kind of rewarding the health center just to create a competition between the health centers. We would call it like establishing model hygiene health centers. So there is a set of criteria. If they meet that criteria, then we would certify them as model hygiene health centers. Some of the triggers that we introduced there was first facts and data-driven discussion. Health providers, they know about the spread of infection, but this was a good repetition that we just bring some data from local context, how the maternal mortality and child mortality can be, prevented by improved hygiene, and how high these numbers are. And then also, kind of warn them against, spreading of infection to themselves. So how they can protect themselves, the healthcare providers. And then we also try to create a sense of pride among the health centers, so that kind of giving them a sense if they achieve this criteria, and then they would be called a model hygiene health centers, and they will be certified, and there would be a plaque. So that's kind of trying to give them a sense that they could be proud of their work. And also then we introduced some nudges, like we developed some new posters with children smiling, and then with them and the message in local language, it says that wash your hands and keep me smiling. It's like a new way of asking healthcare providers in a very emotional and sentimental way to practice behavior. We printed big posters and hang them and on the walls of the health centers, but also small stickers which would be closer on the desk of the doctor or midwife, so that there would be so many, so that they see them, and the idea was just to remind them about what they are doing and how to improve this. As I mentioned, so we try to give it an emotional touch. So it's fact plus emotional touch plus creating a sense of pride for them, and we thought that this would be very useful. And one other thing which we added was that they have to identify one or two people from within the team, so that they are making follow-up visits of everyone, and then see if everybody is practicing. If not, then that person would remind, and we would call them hygiene inspector or hygiene. Even in some health centers they call it hygiene police, and we didn't want to introduce that person by ourselves. So we want them to identify. So this is a person, he's even not a healthcare provider, he's an admin guy in one of the health centers, but the team identify him as a hygiene police because they wanted someone who is trusted for everyone, for all the healthcare staff, and then it could be medical or non-medical stuff. And then this person would regularly observe others, and then if somebody misses, they also created a sort of fun. So this guy would find them, like a very little tiny amount, like 10 cents. So, and then he would collect that money in a box, and then later every month they would just take out how much money they collected, and then they would spend it on something like a feast, a picnic. So this is also something which most of the health centers really like, because this created a synergy among the healthcare providers, but also like a new dynamic for hygiene promotion. In order to implement this program, we needed to develop capacity and locally. So first, as I mentioned earlier, we needed to create a nest in the Ministry of Health, and that was the Health Promotion Department. Together with them, we developed a number of documents. We developed facilitators manual, how to facilitate this whole session, and how to train people. So for that, we did the training material, and then we did facility assessment tool that would be used at the beginning of the program, the sanitary inspection or the transit walk. And then also action planning template and communication material, a lot of posters, leaflets, and stickers, they were developed. And then we trained the primary healthcare supervisors from implementing agencies. In Afghanistan, most of the health services are provided by the NGOs. They are like contracted out to NGOs. So we trained supervisors from those NGOs who should be able to visit the health centers on timely basis. This is just, I took this slide from one of our presentations, like into 2022. These were some of the achievements. They like declare 77 health facilities as model health centers, and they triggered like 200 facilities and some other stuff. And one other thing, as I mentioned, every health centers would develop an improvement plan, and that improvement plan, they would also include some of the missing facilities, like if they miss something in the latrine or in the water facility, and then they would contact the relevant department. So that's why we have a number of improvements and newly built latrines or improved latrines. So this program, however, it was focused on hygiene promotion, but it also created a momentum within the health sector, so that they also mobilized resources to improve the facilities. And this is just a picture of one of the health centers, which was declared as model health facility. And this is the plaque that was, installed on the wall of that health center. So it says that this facility is declared as a model health hygiene health center, and these are the criteria that they met. So everybody looks so happy, and the facility also looks tidy and clean. So the certification criteria was that water would be available from an improved source, and it would be available and accessible most of the time. Improved latrine for male and female should be there. Improve and separate latrine available for male and female patients and also staff. Hand washing facility and point of services, point of care, and then sign off use of those wash services. So during the certification ceremony, we have to see if the facilities were used. So and availability of active incinerator, and also hygiene observer or inspector or police. These are the criteria for certification of the health center. And the process was that first they would do the internal certification. So the health center would discuss if they meet this criteria. After they are ready, then they will inform the health promotion department, and then there would be a joint team from the Ministry of Health and the implementing NGO and some community leaders and healthcare providers. They would get together on a specific day, and then they would do the certification. It was also like a fun activity. So starting from a pilot to a scale. So this program was initially started in 5 health centers in 2017. Then we slowly scaled it up after we refined the concept and the methodology and the material. And then we sought buy-in from the government and other partners. We did capacity building with the Ministry of Health and also with the NGO supervisors and everyone. And then in the coming years, then first we did 60 health centers, then 150 in the next year, and the next year it was 200 health centers. So, but the only thing which was pending was the program evaluation. We didn't do a formal evaluation of the program just to see, how effective it was. However, it was planned. Unfortunately, with the change in the political situation, this didn't happen yet. Some of the challenges in some health centers, it was hard to find a right time, that everybody get together and, participate in this activity, because healthcare providers, they would always say that they're too busy. So that was a challenge. So people should call them several times until they get an appointment. Measuring the progress and behavior change was a bit difficult. It's still a challenge because we relied on self-reporting. So, and we all know that self-reporting is not a very robust way to measure behavior. So therefore, an evaluation is needed to see, how the real change was materialized there. In, lack of facilities, the infrastructure, that was another issue. Sometimes if there is no infrastructure, if they don't have water, then hygiene promotion doesn't really have any meaning. So that was, in some instances, that was a challenge. So we have to wait until they get this facility. And, and due to insecurity and geographical issues and climate, some of the health centers were not accessible. So we couldn't meet them. Some of the lessons learned in this program was that, healthcare providers, despite being, trained in the business of, infection prevention and these things, and doesn't necessarily mean that they're good in practicing hygiene. So we observed that, like, even in that assessment, we found that in some instances it was as low as 24% of cases that they practice hand washing. So therefore, when we are, developing programs for hygiene behavior change or hygiene promotion, we should also focus on health center. Hygiene can serve as an entry point for WASH and health centers. As I mentioned earlier, it's not only hygiene. Health centers also lack water facilities in many instances or sanitation, but hygiene can be a good entry point because it's closely linked with the infection prevention practices or IPC. It's always good to mobilize the whole team so that they kind of encourage each other and create a sustained behavior change rather than focusing a certain group of healthcare providers. Gender equality in accessibility and sanitation facility also can be achieved through working with health centers. We found out that in some health centers there were latrines for both male and female, but then they were locked. Like, female latrine would be locked, but after we introduced this program, we let them know the importance of keeping the latrines open for both male and female visitors, particularly. So that's why this is very important that we remind them about this. So new messages and nudges should be used to change behavior. So it shouldn't be always the same messages, and we have to think about evidence-based communication for behavior change. And then another lesson learned was that this program created synergy between the different partners. In some instances, we found out that there were partners who planned projects on improving WASH facilities. Then we made coordination with them. So the health center was then eventually declared as a model health center because one partner introduced infrastructure, and then Ministry of Health improved behavior and other stuff like cleanliness. So synergy was created there. I think that's all from myself. Thank you very much for your time and attention, and I'll be happy to answer questions.